Hey everybody, welcome to our PRaISE presentation on utilizing the Kawa model in occupational therapy to address mental health of adults with acute neurological conditions. This is a pilot study done by myself, Nicole Sheehan, Neesha Johnston, Jenna Newhouse, and Rachel Tees, and our research mentor was Colton Sayers. To begin, we wanted to touch on some background points that are important to our project. In 2014 alone, nearly 2.9 million TBIs were diagnosed in emergency department visits, hospitalizations, and even deaths. And each year, more than 795,000 people in the United States have a stroke. 15 to 30% of those stroke survivors also suffered permanent disability. These permanent disabilities can affect an individual's ability to drive, feed themselves, work, play with their children, make their own beds, or even buy Christmas presents independently, amongst other aspects of daily life. These changes following an acute neurological injury can be difficult for the human brain to process and let alone cope with. With a focus on this physical health, these psycho-emotional factors can often go unnoticed and fester into larger problems. Research suggests that individuals following neurological conditions tend to experience increased rates of depression, lower quality of life, and decreased social and community participation. And with that being said, depression is the most prevalent mental health concern associated with these conditions. These findings are a friendly reminder that it is just as important for healthcare practitioners to address an individual's mental health as it is their physical. To achieve this, we would like to introduce to you the Kawa model. The Kawa model is a metaphor for an individual's current life circumstance using multiple aspects of a river to guide intervention. The river metaphor is actually used to depict life's journey, and the Kawa model is used in intervention to assess the client and assist them with maximizing their life flow. The Kawa model takes into consideration the past, present, and future needs of the client, and this strategy is known to enhance the client-therapist relationship. Although there is little to be said about the Kawa model specifically with neurological conditions, it has been utilized throughout occupational therapy treatment, and specifically during an 8-week workshop. The Kawa model was determined to be an effective way to enable clients to explore and share their problems. This project was driven by Colton Sayers, a certified neurospecialist in outpatient OT at the University of Cincinnati's Gardner Neuroscience Institute. He noticed that there may be a lack of mental health intervention following an acquired brain injury when he asked one of his patients, "How are you doing?" And this triggered the patient to become tearful because no one had sat down and truly spoke with him about how he was actually doing following his injury. Sayers believed that his clients could potentially experience greater therapeutic outcomes by implementing a tool to directly target their depressive symptoms following an acute neurological condition. The Kawa model was chosen as the exploratory tool for this study due to its holistic nature and ability to relate to each client individually.
The purpose of this study was to explore the use of the Kawa model as a tool for addressing mental health concerns in individuals who experienced an acute neurological injury. Participants included 4 outpatient rehab participants at UCGNI. Characteristics included experiencing depressive symptoms impacting their participation in everyday meaningful activities, less than a year post-stroke or TBI to ensure that depressive symptoms are likely related to diagnosis of ABI, demonstrated ability to comprehend and respond to questions, and they were without extreme aphasia, cognitive impairments, or non-speaking English. Demographics. Patient demographics were blind to researchers in an effort to maintain objectivity. The only demographics that were shared with researchers was disclosed within Kawa worksheets. This is a visual representation of the Kawa model based on our data we will discuss later in the presentation. Health and family were found to be the river flow, also known as priorities in patients' lives. Environments and contacts, also known as riverbanks, were identified as support network and lack of accessibility. Rocks, or challenges, were identified as physical limitations and emotional challenges. Driftwood, or the most influential factors, were identified as spirituality, family and relationships, and persistence. And patients noted potential volunteer and work experience as spaces, which is also known as opportunities to enhance their recovery. Retrospective construct analysis. Data was collected from 8 Kawa worksheets from 4 study participants. Worksheets were coded and codes were identified. All codes were color coordinated to the patient's worksheet from which it originated. The primary thematic analysis by which team generated codes and developed themes. And the secondary analysis, construct analysis with specific information from worksheets used in order to identify commonalities between each construct of the Kawa model.
After the conclusion of both sets of data analysis, major themes were identified both generally as well as construct-specific. First, main themes were identified by analyzing all of the codes found. These themes were the importance of family involvement, physical challenges, and the loss of independence. The first of these was the importance of family involvement. 4 categories were identified: family as a priority, support network, financial stress, and values. Each client noted family as a priority or as an important aspect of their lives, such as their husband providing the most support and being the matriarch was important to them. Secondly is the theme of physical challenges. 7 categories were identified encompassing the changes and impact of the injury that had on the client. Patient 4 specifically mentioned experiencing daily obstacles related to their cognition, balance, and vision, and the new challenges of being able to engage with their grandchildren due to them not understanding their condition. And finally, the third general theme is the loss of independence. 8 categories were identified, and each touched on how the lives of the clients were impacted because of their injury. One client mentioned regaining their independence was a headache. Themes were identified out of the construct-specific data as well. The themes for river flow were health and family, with one client mentioning that they were trying to take care of their physical health and body. The themes for riverbanks were support network and the lack of accessibility. The themes for the rocks were physical limitations and emotional challenges, and each client expressed how these proved to be barriers for them. The themes for driftwood were spirituality, family and relationships, and persistence. And finally, the themes for spaces were volunteering and work and strategies. Several clients mentioned having work/leisure goals for the future and how compensatory strategies will help them accomplish these. There were several limitations to this study that are important to recognize. First, this study had a small sample size of 4 participants. Because of this, the findings of this study are unable to be generalized to the neurologic population and further research is necessary. Secondly, one client did not complete all of the Kawa model worksheets, so there is an incomplete dataset for that client. This fact means there is a lack of data across the clients, and there would have been additional information to have been considered in the data analysis. And finally, the clients who participated in this study may have been experiencing limited cognition or a lack of insight due to their neurologic injury. The client's responses to the Kawa model worksheets may have been skewed, as the patients may have had difficulty identifying appropriate factors for each construct and in making appropriate connections within the worksheets. These limitations should be addressed in further research to increase the validity of future findings.
In discussing the results of this retrospective content analysis, we first expounded on the importance of family involvement. So, family support or lack thereof affects how these individuals tackle obstacles, and the amount of stress or support that a family provides can affect a patient's mental health and how they experience independence, self-worth, and adequacy. So, in working with these clients, it's important for an individual to know how the family is affecting their therapeutic process and mental health. and practitioners are able to increase family involvement by having them be included during sessions or giving patients homework to complete outside of therapy sessions. As for physical challenges, physical deficits and barriers can negatively impact a patient's mental health by fostering feelings of helplessness and isolation from their meaningful occupations. And navigating life with these new challenges can lead to frustration, avoiding these meaningful occupations and activities, and depressive symptoms. At UCGNI, the OTs are able to cater their treatments to simulate these challenges that patients are experiencing by doing more real-life skills like taking them to Starbucks to order for themselves or practice other higher-level executive functioning skills. For lack of independence, families can sometimes be overpowering and stifle progress and independence in an attempt to keep their loved ones safe. Limiting independence can also lead to feelings of resentment, feelings of helplessness, and depressive symptoms. Barriers in one's own home can also thwart independence, and the effort that it takes for those who have experienced these neurological conditions to regain independence can be demoralizing in itself. The loss of one's independence is directly related to decreased engagement in chosen daily occupations. Intervention can assist individuals in regaining self-confidence and increasing self-reliance. Lack or loss of independence can be combated through compensatory strategies, adaptive equipment, environmental modifications, and encouraging autonomy while maximizing independence. As far as implications for future practice and research, having an understanding of typical client factors that affect recovery can help practitioners be prepared to address mental health and depression in treatment, enabling more holistic and client-centered care. By sharing these findings and that of a future larger-scale study, we can inform the practice of not only OT practitioners but all healthcare providers by considering the importance of mental health in treatment. Results from this study indicate that a larger study is warranted to explore the themes discovered and obtain data that can be generalized and disseminated. The use of the standardized Kawa model worksheets in this study was well received by patients and served as a starting point for discussing and incorporating psycho-emotional factors into occupational therapy treatment. In conclusion, following an acute neurological condition, patients' psycho-emotional factors are often overlooked and go untreated, leading to poorer mental health outcomes. Through the use of the Kawa model, this research team found that family involvement, physical challenges, and loss of independence were the primary client factors that impacted the recovery of individuals following a neurological condition. The Kawa model in occupational therapy practice demonstrated its ability to serve as a promising intervention for acute neurological conditions, as it helped to facilitate an open dialogue. By doing so, physical and emotional challenges were addressed through deeper discussions and the implementation of strategies to overcome challenges. Further research is needed to confirm these findings and to evaluate the feasibility of the Kawa model as a tool for addressing mental health. The addition of quantitative measures should be considered to further confirm study findings of the efficacy of the Kawa model intervention. Here are a list of our references, and we thank you for listening.